Good afternoon. Good afternoon. Welcome to the Healthier Washington quarterly webinar focused on core components of the Healthier Washington state-based evaluation. Thanks for your patience as we were working through technical difficulties. My name is Laura Kate Seichkin, and I am the Deputy Chief Policy Officer at the Healthcare Authority, and I will be moderating today's webinar. Before we get started, let's make sure we're all connected. We hope that you can hear us, and there are multiple audio options that are listed here on the screen. Also, we will be taking questions at the end of the webinar and leave plenty of time for questions and dialogue between you and our panelists. But please feel free to submit questions via the chat box anytime during the webinar. We'll be collecting those and answering your questions once we get through our presentation. Next slide, please. Today's agenda, we will be focusing on the evaluation design of the state-based evaluation for the State Innovation Model Test Grant. I want to recognize that Healthier Washington has multiple implementation mechanisms, including the State Innovation Models Grant, foundational legislation, a blueprint that was submitted nearly 3 years ago now, called the State Healthcare Evaluation Plan, and the newest edition of the Medicaid Transformation Demonstration. Today we're going to be focused on the State Innovation Models evaluation and specific components of it in addition to overall impact design. So we have many distinguished speakers and presenters today. Recognizing that the University of Washington-based State Innovation Models evaluation is housed administratively in the Northwest Center for Public Health Practice at the University of Washington School of Public Health. We'll be hearing from Doug Conrad, Dave Grombowski, and Chao Kwan Get to really take a deep dive into what our evaluation design looks like. And also we'll be hearing from Dorothy Teeter, the Director of the Healthcare Authority. She's going to kick us off in asking ourselves, within the spirit of innovation, is this working? So she'll be doing some level setting on Healthier Washington overall, and then taking us through the how and the why of the SIM evaluation. Dorothy.
Thanks very much, Laura, and good afternoon, everyone, on this gorgeous sunny day in Washington. The process for developing the State Innovation Plan, now called Healthier Washington, was intentionally collaborative and reflected a strong public-private partnership. To reach our successful award year 3, we have benefited from the contributions and commitment from many throughout the state. So today I am pleased to be able to spotlight the work of one of those partners, the University of Washington School of Public Health and the Department of Health Services housed within that. The SIM grant is one mechanism for achieving the ultimate goals of Healthier Washington, as depicted on this diagram, to ensure care focuses on the whole person, improve how we pay for services by paying for value rather than volume, and empowering healthier communities through a regional collaborative approach. Our approach to evaluation is intended to promote continuous real-time learning and to facilitate timely responses to changing environmental and market conditions in our state. In that sense, the evaluation will contribute to performance measurement and improvement as part of a Plan, Do, Check, Act, or as we all mostly affectionately call it, the PDCA cycle of innovation and improvement. Successful implementation of Healthier Washington will impact nearly every health consumer and taxpayer in the state. We will be looking to our evaluation to bear this out, but we expect that Healthier Washington initiatives will continue to drive greater returns in later years as delivery and payment reforms take root. So our objective is to achieve the triple aim of better health, better care, and lower costs through improvement. And we have designed our investments and purchasing strategies to add value as fewer people suffer from preventable illness, and through a reduction in the toll illness can take on the state's workforce, schools, and communities. There are many elements in our evaluation of our innovation model. And here's a depiction of those different elements and the folks that are going to be evaluating different parts. But not surprising for an initiative of this size, we've planned for multiple coordinated evaluations. The Healthcare Authority has contracted with UW Department of Health Services to lead the state-based overall SIM impact evaluation, as well as focusing on certain areas funded by the $65 million grant from CMMI, including the three of the overall payment models and the practice transformation hub. A formative evaluation of accountable communities of health is being performed by Group Health Center for Community Health and Evaluation. And finally, the evaluation of Payment Model 1, which refers to the integration of physical and behavioral health payment and delivery, is being performed by the Research and Data Analysis, or RDA, division of DSHS. In addition to our state evaluation, CMS has also contracted for a federal evaluation to evaluate not only our innovation model, but other states as well. So let's begin with a look at how we will evaluate the overall impact. The lead for this task is David Grambowski, and I'm going to turn it over to David right now to lead us through that overall approach.
Thanks very much, Dorothy, for that wonderful introduction, and I'd like to welcome everybody on the webinar from on behalf of the University of Washington and the School of Public Health. I'd like to walk you through kind of the overview in terms of the overall impact evaluation of the SIM grant, and to review its major features. So one of the things that we've done in terms of organizing our evaluation is to choose an evaluation framework. And for this purpose, we have chosen a relatively well-known framework, Russell Glasgow's RE-AIM framework, which specifies the dimensions of a program that the evaluation will be looking at. Just following the letters down, REACH gets at percentage of the target population, both in terms of the practice population and Washingtonians that receive the program, the effectiveness or the impact of the program, the adoption in terms of the percentage of settings that adopt the program, implementation in the field, as well as maintenance. And many of these domains are going to be covered in our evaluation work, not just in the overall impact evaluation, but in all of the components. So in laying out the overall SIM impact evaluation, what we've tried to do is, first of all, think about the three major aims of the SIM project, which is to achieve better health, better care, and at lower cost, the so-called AAA. And so parallel with those aims, we have formed three kind of parallel questions to guide the overall SIM impact evaluation, which is to answer these three main questions. What is the effect of the Washington State Innovation Model on population health, as well as health equity across social population groups? Quality of care, particularly for those persons living with physical and behavioral health comorbidities. And lastly, the annual growth of healthcare costs per capita in Washington State. Now, before we went much further in answering these questions, we decided the next step was to get our evaluation team organized in terms of thinking about exactly what the SIM evaluation or SIM project is and how it works. And this is a rather detailed and busy slide. It's called the driver diagram, and it was actually mandated by the Center for Medicare and Medicaid Services to spell out what the SIM intervention is and how it is, and what are its main components that will achieve its goals. So let me kind of walk you through this briefly in terms of what are the major columns in this diagram. So on the far left are the aims of SIM. That is, what are we trying to achieve and accomplish? And it's basically by 2019, Washington's healthcare system will be one where 90% of Washington residents and their communities will be healthier. All people with physical and behavioral health and substance abuse comorbidities will receive high quality care, and Washington's annual healthcare cost growth rate will be 2% less than the national average. Then, within this diagram, there are quality outcome targets, basically that are a subset of the common measure set that has been established for the state of Washington. And then the third column are investment areas, which are the three primary domains or dimensions where SIM is investing in to achieve these goals, which are community empowerment, practice transformation, and payment redesign. Then, within the next column, there are primary drivers for achieving each of those aims, or each of those investment areas. For example, in payment redesign, there are 4 payment models that are, which you'll be learning about later in this presentation. There are also secondary drivers, for example, that define the settings where those payment models are going to be implemented. And then finally, there are metrics in terms of standardized measures for assessing progress in achieving those goals for each primary driver and secondary driver. The other mechanism that we have developed to understand the overall SIM project and how it might impact outcomes is through developing a conceptual model. And on the left-hand side, there is a box labeled SIM intervention that lists the 3 major components of the SIM project, like the accountable communities of health, practice transformation support hubs, and payment reform, as well as support from the AIM component. On the right-hand side, on the far right-hand side of this diagram are the 3 major outcomes of SIM: improve population health and health equity, improve quality of care, and reduce cost growth. In the middle are pathways that show how the SIM intervention on the left is expected to achieve those outcomes on the far right. And fundamentally, the basic message that the conceptual model is conveying is that in order to realize the individual level outcomes on the far right, SIM needs to first change the environment and change the healthcare system and the social service system in Washington through, for example, building capacity in accountable communities through accountable communities of health and doing regional planning, implementing regional health improvement projects, changing policies and systems which may lead to changes in health behavior, which may reduce health risks and lead to better health. The 3 other the components may also operate individually and in combination with each other to change how we deliver health care, improving service integration, reducing inefficient services, increasing coordination of services, reducing use of services such as reducing emergency room visits, which we think will reduce unmet needs and lead to greater improvement in quality and reduced cost growth. This conceptual model is very useful also in thinking about what the overall impact evaluation should be focusing on. So in terms of the methods, in general, we are using a mixed methods approach. Now, in evaluation, when we use the term mixed methods, we're generally saying we're going to be using a mixture of quantitative and qualitative methods in the overall SIM impact evaluation. So for the impact, for answering those 3 main questions that I described earlier, we're going to be applying quasi-experimental study design and regression statistical analyses to estimate SIM impact on population health, quality of care, and cost growth in Washington. We're going to combine that with a process evaluation component where we're doing qualitative key informant interviews and content analyses of program documents to learn what's going on in SIM on the ground. Plus, we have a monitoring scheme in place where we're quantitatively tracking SIM implementation, partly through the metrics required by the Center for Medicare and Medicaid Services. So what is triangulation? It's simply the idea of taking the results that we see in the impact evaluation and cross-checking whether they're consistent with the results that we're seeing from the process evaluation to make sure that our conclusions are accurate. Now, in terms of timeline, the SIM project runs for 3 years, 2016, 2017, and 2018. The quantitative impact evaluation will be drawing on and utilizing data mainly from 2 years, 2016 and 2017. We have to finish up our work by the end of 2018, and so basically, in terms of the available data, it limits us to those 2 years. For the process evaluation, we'll be collecting data from all 3 years. And then for my last slide, just to give you a sense, we'll be looking at a variety of outcome measures for each of the 3 major outcomes: population health, quality of healthcare, and cost growth. These just are intended just to give you a flavor of what some of those outcomes are that we'll be looking at. So this concludes this section, but I wanted to say before I pass it on to Tao Kwang Get that the impact evaluation is just one part of the overall SIM evaluation, and we really have to look at what each piece of SIM is also doing to really understand what's going on. So I'll now turn it over to Tao Kwang Get.
Thanks, Dave. For this section, I'll be talking about the evaluation of the Practice Transformation Support Hub, which has the 3 primary objectives listed here from the Hub website that many of you are familiar with. The first is to stimulate and accelerate the uptake of integrated and bidirectional behavioral health and primary care, support progress towards value-based payment systems, and improve population health by strengthening clinical practice alignment with community-based services for whole-person care. For each of these objectives, the University of Washington team has developed a corresponding evaluation question to assess the impact of the Hub. For example, for integration, we want the evaluation to identify what Hub activities advance bidirectional behavioral health and primary care clinical integration. Correspondingly, for value-based payment and community clinical linkages, our evaluation questions focus on identifying what activities advance practices progress towards these objectives. In addition to the evaluation questions focusing on impact, we also have evaluation questions focusing on implementation. As you know, the Hub is currently implementing its 3 primary components: a web-based resource portal that provides a clearinghouse of curated resources and training, a regional health connector network, and practice coaching, facilitation, and training services. For the implementation evaluation questions, we've developed 2 practical questions whose answers could help the Hub improve its implementation and processes. One evaluation question is on lessons learned. What lessons have been learned in the process of Hub implementation that can improve Hub services and shape the future direction of the program? Another evaluation question is identifying the facilitators and barriers for achieving Hub objectives. To guide our approach to the Hub evaluation, we used a hybrid of 2 frameworks that have been published in the implementation science literature. One is by Gregory Ahrens from the University of California, San Diego, who developed a model of evidence-based practice in public service organizations. And the other framework is by Tricia Greenhall of University College London, who conducted a systematic review of diffusion of innovation in service organizations. In this hybrid framework, we look at Hub implementation in 4 different stages: an exploration stage, a pre-implementation stage, an implementation stage, and a sustainment or sustainability stage. And throughout these stages, we'll be looking at factors at 3 different levels: intervention factors, internal factors, and external factors. In each of these stages, intervention factors can impact how it is implemented. For example, in the exploration phase, If a hub intervention is easy to understand and appears to offer clear advantages, it is more likely to be adopted than an intervention that is complex and offers little relative advantage. But we also have to look at internal factors related to the organizations that will be implementing the intervention. For the hub, we consider the internal organizations to include the Healthcare Authority, the Department of Health, the contractors for the hub, Qualis Health and UW Primary Care Innovation Lab, as well as the practices themselves. If these organizations have strong leadership, are ready for change, and have goals that align with hub objectives, the hub intervention is more likely to be implemented than if these organizations lack these characteristics. And finally, of course, implementation is going to be greatly influenced by external factors, such as funding, legislation, and networks with other organizations, such as the Accountable Communities of Health. At UW, we are carrying out the components of the evaluation in a sequence aligned with these 4 intervention stages, which are in the top row of boxes. And the second row of boxes represents the components of our evaluation. The first component of the evaluation was the formative evaluation, which was conducted in the fall of 2015 as the hub conducted listening sessions, site visits, and other stakeholder activities to determine the training and technical assistance needs of primary care and behavioral health practitioners. The second component of the evaluation, which we're in now, is the process evaluation, which will cover the implementation stages of the hub. This component of the evaluation will produce quarterly rapid process improvement reports to help inform hub implementation. The third and final component of the hub evaluation will focus on outcomes, answering the 3 evaluation questions that we presented earlier. So far, our team has completed the deliverables for the formative evaluation and are currently working on the deliverables for the process evaluation. Our formative evaluation report, published in 2016, summarized the findings of the stakeholder activities as mentioned earlier. We also conducted a series of key informant interviews to get more insight into practice transformation needs. Some of the cross-cutting themes we heard included practices face many data collecting and sharing challenges, and some of these challenges are due to limited funding and resources, particularly around information technology. Stakeholders said for each of the 3 hub domains of care integration, community linkages, and value-based payment, people need examples of best practices to be able to envision what success looks like. And to get there, the practice community said they need strategic leadership to show concrete steps forward. We are currently working on the deliverables for the process evaluation, and so far we've submitted reports for the 3rd and 4th quarters of 2016, which focus on the pre-implementation stage of the hub. Our findings in those reports included a reinforcement that practices have limited time, energy, and resources. Clinicians in both physical and behavioral health are already incredibly busy in their daily work, even before added challenges of practice transformation. Therefore, clarity in hub mission and vision is critical to success. And to convince practices to engage with the hub needs to articulate the value of practice transformation so that clinicians can know how it will benefit them and their patients. Another finding was the need to coordinate with Accountable Communities of Health, Medicaid transformation, and other practice transformation efforts in the state. For the final evaluation report, stay tuned until January 2019, when our team will submit the report at the end of the SIM project period. Obviously, the hub evaluation will require the collecting and analysis of a lot of data, so I'd like to give now an outline of the data collection infrastructure for the evaluation that we're working on with Qualis Health and UW Primary Care Innovation Lab. To answer the evaluation questions on which activities advance practices development and hub goals, we need to be able to measure 2 groups of data. One group is activities, and the other group is development. To measure activities, let's look at this arrow, which represents the time a practice engages the hub for practice transformation. From the time it is recruited to the end of the project period, the practice might receive coaching activities or use the web portal. Coaching activities will be captured in a web-based tracking system called TrueServe, which was developed by the Center for Rural Health at the University of North Dakota. Web activity will be captured by the subcontractor administering the Hub Resource Portal website. To measure development, we need to assess practices in at least 2 points of time. Currently, we're in the process of developing a brief questionnaire that could help a practice assess where it is at in terms of care integration, clinical linkages, and value-based payment. Our hope is that such a questionnaire could capture the development of practices when they are first engaging with the hub, and then again later when the practice has worked with the hub coaches, connectors, and resource portal for some time. But to really understand the nuances and complexities of practice transformation, we have to talk with people and learn from them firsthand what the success factors and barriers have been. And for that, the UW evaluation team will be conducting key informative interviews with a subset of practices. This data will be housed at UW, where we will integrate it with data from TrueServe, Resource Portal, and Qualys. And with this data, we'll be well positioned to describe and evaluate the important work of the hub. So that's a brief interview of the hub evaluation, and I'll now turn things over to Doug Conrad, who will discuss the evaluation of the payment models.
Thank you very much, Tal. One thing I want to say at the outset is that there are 4 payment redesign models in the SIM and in Healthcare Washington. The first one, Payment Model 1, refers to the integration of Medicaid purchasing for physical and behavioral health. That piece of the evaluation is being performed by the Research and Data Analysis Division of DSHS, and we are strongly coordinating with them so that the whole incorporates all the parts. But I'm going to discuss today the 3 payment models that we are accountable for leading at the University of Washington. This first payment model 2, or model test 2, is shifting from encounter-based fee-for-service type models to value-based payment, a key part of overall SIM. For this portion, there are 2 versions of payment redesign being developed. One is on the ambulatory care side. Value-based payment models are being developed for federally qualified health centers and rural health clinics. Now, on the inpatient and hospital side, because hospitals participate in both ambulatory swing bed services as well as inpatient services, is value-based payment redesigned for critical access hospitals. I'm giving here some examples of key evaluation metrics that we'll be looking at. One is the total cost of care per member month. Another is the healthcare effectiveness and data information system clinical quality metrics, or HEDIS, with which I'm sure many of you are familiar. The third and final is population health and screening measures. We want to look at the effects of this kind of payment redesign for both the ambulatory and the inpatient side on these kinds of evaluation metrics. The next payment model for which we are primarily accountable evaluating is what we call Model Test 3, or Paying for Value, High Value Accountable Care. There are 2 accountable care networks that have been created in Washington in the first phase that are in place for public employee benefit members. The first, the Puget Sound High Value Network, is housed and led by Virginia Mason Health System. The second is the UW Medicine Accountable Care Network, as the name suggests, led by UW Medicine Health System. The value-based payment redesign that is reflected in these 2 ACNs, or accountable care networks, involves a contract that has both potential for upside gains, or sharing, as well as downside financial risk based on quality performance metrics that are linked to a subset of the statewide set of common measures. So there's that integration between the overall goals of the state of Washington and the particular evaluation of payment design. Again, evaluation examples of the metrics include total cost of care per member month, preventive measures and screenings, the care of chronic conditions, and not mentioned explicitly on this slide, but it also includes broader measures of the quality of care impacts. And when we say quality of care, we're generally focusing on process measures and structural measures of quality of care. When we talk about outcomes, we're talking about actual changes in physical or somatic health, as well as measures of mental and behavioral health. So that's the perspective we take on Payment Model Test 3. The final model that we evaluate is called Paying for Value, or often also called Greater Washington Multi-Payer. In this case, the model starts with some real changes in information flows. The intent of this model is to speed the adoption of value-based purchasing by increasing the access that providers have to both clinical information, electronic health record, and utilization data across multiple payers, trying to get a population health view for the entire panel or large component of the panel that the provider faces. The key innovation here is integrating electronic health records information, clinical, with claims and encounter information, utilization and financial, into providers' workflows. So again, the payment system, the data aggregation solution of these two flows, clinical data and claims data, are meant to promote improved provider work and really get an integrated view of the patient. Secondly, in January, in a release that came out January 11th of 2017, contracts have been executed with two pilot provider networks, one rural-based, Summit Pacific Medical Center and their affiliated rural health clinics, and one urban-based, the Northwest Physicians Network, headquartered in South Tacoma, and with a large number of providers. Again, key examples of evaluation metrics, no surprises here, the triple aim, total cost of care per member month, population health metrics of actual outcome, and clinical quality metrics for not only children and adolescents, but for adults as well. I'll conclude my presentation here by talking about our general payment model evaluation design. It's essentially grounded in a comparison between participants in these payment models and non-participants who are similar or comparable on important metrics that might be expected to influence outcomes, cost, and quality. So we are at pains to construct a similar control group or comparison group of non-participants who, except for participation in the program, are systematically like the actual participants in the model test group. Now this diagram is a hypothetical. It says, suppose on per capita healthcare cost per member per month, that initially the comparison group has somewhat higher level of cost. So I've drawn that line, if you will, so that it's above the line for the model test group. It could be identical. In fact, we'd love to find a comparison group that has the same starting conditions, but at least we want the same trend, or in this case, no trend. And then I've introduced an arrow at the point that says model start, that arrow down. At that point, let's say that the comparison group experienced a slight decline in their rate of healthcare costs, and that's shown by just a modest decline in the comparison group line after model start. Second part of this is the model test group. Again, hypothetically, suppose that the level of cost for the participants in this payment model dropped there at the time of model start. There was a lot of anticipation. They tooled up, they got ready, and they hit the ground running and had some real achievement. Are we likely to see that? Well, time will tell, but we're not betting the farm on it. Now, secondly, and perhaps more realistically, it shows a decline after model start in healthcare costs over time. And notice that that line is steeper, and its decline is steeper than that for the comparison group. This would allow us statistically, after adjusting for other factors that are outside the intervention, to make a statement about whether the comparison group and the model test group had a different experience. And actually, we're trying in our evaluation to find cause and effect where we can, or at least plausible attribution of the results to the SIM itself. So this concludes my formal part of the presentation, and I think that, yes. And I'll advance the slide, and I think Laura K. Seisman has some comments here.
Thanks so much, Dorothy, David, Tao, and Doug. We now are opening it up to questions for the remainder of the hour. And you can use your questions panel to type questions in, and we'll be answering them as they come in. We did receive a couple questions throughout that we'll get started with. So I think that, Doug, this can go to you. There are a lot of moving parts when it comes to health reform and health care and health transformation at this point in time, and a lot has changed since the evaluation design was put together 3 years ago now. How does this impact evaluation and all of the different formative pieces as well, how do those take into account all of the different moving parts around federal paying for value efforts, multiple practice transformation efforts in Washington State, and the Medicaid transformation that is new and going to be big in Washington?
I would give the following answer to that. First, the slide in which I showed what our evaluation design was, the use of a comparison group or a control group in addition to the model test group, helps us here because presumably those external factors, including Medicaid transformation demonstration, things that might happen with respect to changing pharmacy practices, changes in service delivery that are not part of SIM per se or Healthier Washington, but are introduced by the federal government, for example, MACRA or MIPS, which are acronyms we're all getting familiar with. Presumably those would hit the control group, the comparison group that's not participating in a particular SIM intervention, and the actual SIM intervention sites of the model test group at the same time. Now, if we've chosen the control group well, they are comparable in many respects in the same area of population, subject to some of the same factors. That should help us a lot. The second thing is our qualitative evaluation, our process evaluation that we talked about. Being out interviewing folk, following content of program documents, being in close touch and embedded to some extent partially with leaders and stakeholders will help us identify what some of the shocks are in the system or changes, and we'll expect blips in our outcomes and be looking for those. In fancy words, we call that interrupted time series sometimes, interrupted by events that we can name. Now, there are limitations on that, but that's the second thing that we'll do. And so trying to trace a narrative, the use of control group, and keeping our eye on shocks and changes that occur over time. I'd say those are the three key parts to trying to make sure that we're really picking up effects of SIM and not something else.
Great. So Dorothy, you mentioned at the start of the webinar that Healthier Washington as a whole really is a public-private partnership. Talk about how that has an impact on the evaluation, its completion, this rapid cycle piece of the evaluation. How do we need our partners to engage, and how have we seen partners engaging as we learn as we go and as we evaluate the impact?
So I think one of the things about the state of Washington is people are pretty familiar with the concept of rapid cycles evaluation, and either for improvement or for innovation. So that in and of itself, whether you're a public or a private organization, and I would say it goes beyond healthcare to some of our ACHs as well as some of the other community-based organizations, are all understanding that what we're trying to do is not absolutely perfect randomized control trial at all, but much more being able to track, as Doug was just describing, what's happening as we start, not only at the end, but during the implementation itself and what the impact of that implementation has. So I would say that the key things that we really appreciate with our partnerships is that engagement and that understanding that nothing's perfect. It's a rapidly evolving system, and honestly, the more people that jump in at the beginning, whether it's the size of the population or the number of practices, the better, because the more numbers we have, the more powerful the results are that we can reach in conclusion. So I think it's that both luckily we've got a state that's got that clear understanding of what we're trying to do, and some patience as we're doing it, and also some impatience as we start to move forward.
And anything to add, Doug, Cal, David, you talked a little bit about some of the kind of methods that in which you'll be reaching stakeholders and people who are part of Healthier Washington. Is there anything that you would add as far as any asks for those who are on the webinar, or ways that they can engage, either in addition to or just building upon some of the methods you already outlined?
Well, this is Doug. I'll just offer a brief reflection and defer to my colleagues. But I think for stakeholders who are either acting in provider roles or payer roles or purchaser roles or almost in public health, whatever it might be, keeping us in mind, we don't mind receiving communication from time to time saying, are you addressing this? We'll give you an honest answer as to whether it's within scope or not and what we think. We hope those of you who are in a position to implement will implement. and do it carefully but rigorously. And there's risk involved here, we think, and it's controllable, but taking that on is no easy task. And as we watch what's going on, I think I'm certainly impressed with the pace of what people are trying to do, both on the payment side and the delivery side. And as Tao talked about, the integration of the clinical practices with the community and the social resources. So I think if people on the horn, here as part of the audience, can keep us honest by asking us questions, and as evaluators, we're open to those, and just trying to implement this honestly and rigorously. I think it's a wonderful idea. We have to remain objective, and we will and are, but we're rooting for success. And so whatever you can do to push these AAA pieces along.
This is Tao. I think for the Practice Transformation Support Hub, primary care and behavioral health is already a mix of public and private. And for the evaluation, I think what will be really helpful will be to hear from practices, first where they are now with regards to each of the hub objectives, and then later on near the end of the evaluation period, what progress that they've made. So for many practices that interact with the hub, whether that's with the resource portal or with practice transformation facilitators and coaches, or the regional health connector network, you'll have an opportunity to participate in practice assessments at the beginning of your engagement, during, and then at the end. And so your frank assessment of where you're at and your honest assessment of the progress that you make while engaging with the hub, I think will be really helpful for the evaluation.
Great. We have received some specific questions about the Practice Transformation Support Hub and that evaluation. I think one of the innovations in Healthier Washington overall is that we are looking outside of the delivery system and really including health as a piece of sort of the impact and also the intervention for Healthier Washington. So when we look at the clinical community linkages piece in the Practice Transformation Support Hub, how do we define that? And then also, are there specific metrics that you're looking at when we look outside of the traditional healthcare system and really look at how the hub is playing a role and how Healthier Washington overall is playing a role in those clinical community linkages and social determinants of health?
Yeah, that's really a great question, because clinical community linkages will mean different things to different people. For some healthcare providers, it will mean the ability to help their patients with chronic conditions such as diabetes, link with resources in the community that can help them better manage their condition. For other practitioners, community clinical linkages might be more related to the social determinants of health, such as housing, employment, transportation. And so for them, perhaps getting a person who's homeless with severe mental illness into housing would be an important example of community clinical linkages. So I think we're interested in both. I think what's important is that these linkages are engaging with organizations that we normally think of as being outside the healthcare system, and looking at health as a more holistic outcome that needs to involve more than just the healthcare system. For the evaluation, we're going to be looking at practices' self-assessment of their development. So in a way, we're almost letting practices define for themselves what they mean by clinical community linkages. And our assessment will measure where they're at with regards to, are they in the planning stage, are they in the exploration stage, are they implementing, or have they implemented and are now evaluating. And so whether they're interested in chronic disease management or addressing the social determinants of health, our evaluation will give them the opportunity to assess their progress in those areas.
Great. So practice transformation includes, in Healthier Washington, includes the Practice Transformation Support Hub. There are other innovations in practice transformation that are coming out of Healthier Washington and through other mechanisms like shared decision making, the certification of patient decision aids, and telehealth. Can you talk a little bit about how we're looking at some of those additional practice transformation innovations and how we're either already seeing or may see some impact on quality through those innovations?
Yeah, that's a really important question. Shared decision making is a very important philosophy, if you will, of how healthcare providers and patients can work with each other more as equals. The effort is starting with a pilot project looking at a decision aid that can help women who delivered by cesarean section previously talk to their healthcare provider about how to deliver their current pregnancy. And so we have a small team at the University of Washington who's helping evaluate the implementation of this pilot shared decision-making module in a few different pilot sites. The hub evaluation itself probably won't be getting too granular in terms of the impact or the clinical impact of specific interventions. We'll really be looking at a higher level to answer the 3 evaluation questions that I described, and measuring practices' self-assessment with their progress along each of those. I think it would be very interesting at some point in the future to maybe look at the impact of practice transformation on clinical outcomes, and that might be something to pursue perhaps as the next step.
Thank you. So we've been focused today on certain components of the state innovation model test evaluation. But as we said at the outset, Healthier Washington is inclusive of the state innovation model test and the Medicaid transformation demonstration. The SIM and the Medicaid transformation demonstration and other interventions and implementation mechanisms all impact and play a role in Healthier Washington, as Dorothy talked about earlier in the webinar. But Dorothy, do you want to expand on that a little bit more around how SIM and the demonstration interact with one another, and as we look forward to looking at the whole picture of Healthier Washington, how evaluation might play a role in that?
Sure, well, I'll get started and then I'll turn it to our evaluator experts to talk about how evaluation can play that continuing role. There have been a lot of questions about how the innovation models or SIM work that we've gotten funded from CMS interplays with the waiver, which is also something that we've contracted with CMS for. And I think there are, I would say in one way, if you think of the umbrella as Healthier Washington as the big picture transformation that we're trying to do in our state for our health system, there are several things that are similar or kind of foundational to both the waiver and to SIM. First of all, the concept of value-based purchasing. Second, the concept of rapid cycle innovation, improvement, and evaluation. Third, and maybe I should have said this first, achieving the triple aim. Fourth, it's a multi-sector approach in both of them. And fifth, I think, is that the common measures that are going to be common to both of them, which are it's going to enable the evaluation to move forward. Both the ACHs as well as the Practice Transformation Hub were built out of our dollars that we received for SIM, but in fact will get expanded and leveraged or activated more through, I think, the waiver. Perhaps the couple of key differences, I think, one is that SIM is really designed to be for all folks in the state, not just Medicaid. The Medicaid waiver is really designed to improve services for that particular population. However, because we're a multi-payer state, the way that we design what we're doing for the waiver should help strengthen the delivery system for everybody that lives in Washington State. A key difference between the two is the amount of money, obviously, with the waiver is much bigger to actually really deeply invest. And secondly, you have to earn the money in the waiver. I should say the Medicaid transformation demonstration project. I still don't have it right. I call it the waiver. But at any rate, there's more money, but also you have to earn the money. So you have up to $1.5 billion that's available. But if we don't succeed in some particular area and hit the targets that we're planning to, you don't get those dollars. Or alternatively, we can have the option of going, wow, that just didn't do what it was going to do. Let's change courses. So they're really different in that sense, but I think overall the message I would love to leave is we're trying to make common measures and really carefully define populations. So as those of our partners that I'm sitting with today are helping us evaluate, we have some sense of what's working and what isn't and why. And that overall it's a triple aim, multi-sector. I guess the other final thing would be with the social determinants, there's much deeper investment in housing and supportive employment with the waiver. So again, we can expand upon that a little bit more as we move forward. So that's a start. Anything else you guys would add to that? Dave?
Well, I think that the Medicaid transformation dollars, I think Dorothy made a great point that those dollars are not targeting all Washingtonians, but basically individuals who are eligible for Medicaid. And so that does provide one strategy for trying to separate out the overall SIM impacts and implementation for Washington State as a whole, versus the Medicaid population. I think the other thing is that from an evaluation perspective, the other thing that we have going on is that the Medicaid transformation is starting at a different point in time than the SIM evaluation. It's starting at a later point in time. And when we have described to you that we are doing qualitative key informant interviews, in many cases we'll be interviewing the same people over time and be able to sort of track the history of their experiences with these interventions over time. And that may also provide us with some qualitative insights about the differential influences that SIM versus the Medicaid transformation are having.
All right. Thank you so much to our panelists today. I particularly want to thank our colleagues at the University of Washington, as well as our HCA Director, Dorothy Teeter, for leading such a robust discussion and providing an update on the evaluation design. Our slides from today and a recording of this webinar will be posted to the Healthier Washington website in a few days. There are multiple ways to contact us, which are up on this final slide. I encourage you to join our feedback network, visit the website, and also follow the Healthcare Authority on Facebook and Twitter, and track Healthier Washington activities through those mechanisms by using #HealthierWA. Thank you so much for joining us today, and have a great week, everybody.